Welcome to the Transplantation Podcast. Here we explore the latest insights at the intersection of medicine and science and focus on getting a little bit more in depth with papers and their authors. I'm your host, Dr. Macy Levan. I'm the social media editor of the Transplantation Journal and Transplantation Direct. Today, we'll be talking about sex disparities in solid organ transplantation, why girls and women often face more barriers than boys and men when it comes to getting on the transplant wait list, receiving organs, and survival after a transplant. Our guest is Dr. Bethany Foster, a pediatric nephrologist and researcher at McGill University. She's also the chair of pediatrics. In her recent review, published in Transplantation, she synthesizes the latest evidence on where and why sex differences occur and what we might be able to do about them. Dr. Foster is a professor of pediatrics at McGill University and a pediatric nephrologist at Montreal Children's Hospital. Her research focuses on long-term outcomes in children and young adults with kidney disease and transplantation. She's had a particular emphasis and focus on sex differences. Dr. Foster, thank you for joining us today. And before we dive into the data, what drew you personally to study sex disparities in transplantation?
So, as you said, I'm a pediatric nephrologist. I'm at McGill University in Montreal and at the Montreal Children's Hospital of the McGill University Health Center, long title. And I'm also the chair of the Department of Pediatrics and the pediatrician in chief here at the Montreal Children's Hospital. I am an epidemiologist. I trained at University of Pennsylvania, and I study, long-term outcomes in young people with transplants, largely, a few other things. And I became very interested in sex differences in transplant outcomes when I started to notice some sort of confusing results between some of the different types of studies I was doing. So I'll tell you exactly what the weird thing was, which was that in many of the epidemiologic studies I did using large databases, we would always put sex in as a covariate in our models. And we kind of consistently were seeing poor graft survival, poor overall survival in females than males. And we just kind of said, okay, maybe it's something to do with girls and women having poor medication adherence or something, but we're not going to deal with that. We're just going to leave it alone because that wasn't what we were really interested in. And then I spent a decade of my life doing adherence research and actually ran a randomized trial of an intervention to improve medication adherence in adolescents and young adults with kidney transplants. And from those data, we actually observed better adherence in females than males. So that made us kind of go, huh, what's going on there? And
Okay.
then, yeah, so that kind of started the whole thing. And we started looking at sex differences in graft outcomes. And then as we were publishing our first papers from that, I kind of got drawn into the Women in Transplantation group. That's an initiative of the Transplantation Society, and developed other collaborations, and then got another grant really specifically focused on studying sex differences.
Well, that's fantastic. So you thought it could be one problem, but it really wasn't that problem. And so now you're able to kind of, through your research, explore the actual reasons for why women have more difficult time with things like getting on the wait list, actually getting those organs, and surviving after transplant. But are you really only focused in the pediatric and adolescent population with this work?
So I'm a pediatrician, and that has been my interest, although, I laughably said when I got my epidemiology degree that I just realized that pediatric nephrology and epidemiology are fundamentally incompatible. And so, it was a bit deliberate that I decided to focus on the young adult and adolescent population because it kind of expands my age range to have a few more people. And I have been quite deliberate, I guess, about having a foot on each side of the pediatric adult divide in most of my research. And so as I started exploring sex differences, I thought there would actually be great strength in studying the entire lifespan. Um, and the reason that I wanted to do this, it wasn't kind of an accident or just to get a bigger sample size, which of course I did. Um, it was really because we know that phenotypic expression of sex differences varies across the lifespan. The sex differences in infants are not that big. Post-puberty, much bigger sex differences with differences in sex hormones and all kinds of things that differ. And then post-menopausal age, the differences get smaller again. And so if you're going to look at sex differences, you have to take this into consideration that existing sex differences may not be the same at every stage of life. So it was a deliberate decision to study the entire lifespan. And of course, when we did that, we found very interesting things, which was that we saw very, very different things in the postmenopausal age group in older women and men than we did in the younger age group. Now, as we've done much more work, not just on graft and patient survival, but on access, and a lot of that work, I have to give credit to Amanda Vinson, who's done most of that. Um, we've started to realize that there are a lot of biases into who gets access to the wait list, who gets access to a transplant, and that may influence survival in different ways for different people at different ages. Um, so it is super complicated, multiple factors going in different directions. I don't think I can say that any of the work we have done um, is going to tell us why there are sex differences because we're doing these in large databases. It is only telling us that there are sex differences and what they are. And if we're able to put in enough specificity, which means interactions in our models, um, we're able to get closer and closer to understanding what the factors may be, um, and what the biases could be that are influencing the outcomes. So I think it's been important to sort of shine a light on it and say, these are the differences we see. We need to understand why, but there will have to be more specific studies to really understand what are the things that are making the difference so we know what interventions we have to do to change the outcomes.
Now you're speaking my language. I'm a qualitative scientist, so asking those questions of people. Well, let's get to the future in a little bit. I want to start with where you just kind of left off with access to transplant and why women can lose ground here. So, for people who are listening, let's talk about the steps, right? So you have referral, waitlisting, actually getting transplanted. And so let's talk about, maybe this in the context of a series of gates in the transplant journey. At almost every gate, your work has found that women are at a disadvantage. So let's start at referral and evaluation from the very beginning. What do we know about sex differences in referral rates for kidney, heart, liver, and lung transplantation from the big data set that you've been working with?
Yeah. So I think we know the most about kidney. And there's a lot of reasons why we know the most about kidney, largely because people with kidney failure can be alive without a transplant. They have dialysis and they can go on for quite a long time. So there have been a number of studies looking at referral rates, and mostly what those studies have shown is that in younger women, um, there's not a big difference. Younger women versus younger men, there's not really much difference in terms of referral rates that have been picked up in the studies. But in older people, women have consistently lower referral rates than men. And this gets worse with increasing age. Um, There has been some qualitative work done to kind of look at why that might be. And I think the reasons are complex, which isn't very surprising. Um, in those qualitative studies, I think it's been shown that women are um, less likely to request referral, less likely to feel that they're deserving of a transplantation, and even if referred, less likely to complete the transplant evaluation compared to a man. So part of it is sort of self-selection. Uh, Women self-select not to go forward with this for a variety of different reasons. Um, and, I'm speaking mainly in the context of the developed world, where in rich countries, in poorer countries, of course, it's very, very different, right? Women hardly ever get transplanted, but they give organs all the time. Um, so I'm going to sort of set that aside for a moment. But in United States and Canada and in Europe, we know that women are less likely to ask to be referred, and that gets worse with increasing age. There are some theories reasonably well supported with circumstantial evidence that one of the reasons for this is that women are judged to be less fit for transplant than men, even when they're actually more fit. So women with obesity, for example, are um, disproportionately less referred for transplant evaluation than men with obesity. Um, and women who are referred tend to have fewer comorbidities than men. One of the factors that may be playing a role, and there's reasonable evidence to support this, is that women may be judged to more likely to be judged to be frail than men. And some of the data are pretty compelling, showing that women who are judged to be frail, so the sort of frailty score in women is not correlated with mortality at all, but in men it's highly correlated with mortality. So there's ongoing work to look at the impact of frailty, which is probably playing a huge role in the older population, over 60, over 65. In
Makes a lot of sense.
yeah, in children, there is actually still a sex bias, primarily with referral for preemptive kidney transplantation. So before needing dialysis, males are more likely to get a preemptive transplant than females. And that's a bit of a surprising finding that I'm not sure I can explain. Most of the big disparities are in older people and in kidney. I have not seen any data in liver or lung. Um, in heart transplantation, there are no good studies on that I've ever seen anyway on referral. But we know that women are as likely or more likely than men to die of heart failure, but less likely to get ventricular assist devices and less likely to get transplants. So it's hard to imagine what would be the reason for that, except that women are less likely to be referred for transplantation.
That is all very interesting. I just want to clarify with you and also for our listeners, when you say older, we're speaking of 60 plus or 40 plus? What's old? What's older?
Yes, good question. I'm trying to remember the specific studies. The Canadian study was 60 plus. Um, there was at least one American study that certainly showed like the biggest disparities in women. I think it was 60 plus or 65, but there were still disparities in more middle-aged women. And I don't remember the exact cutoff, whether it was like 40 or 50. I can't remember, but there were still disparities.
Unfortunate, but true. And something, if we don't talk about it, we can't solve it. And if we don't learn why, we can't create interventions to make it better, right? So let's move on to waitlist activation. So basically, on this transplant journey, and we're talking about the gates of access to transplantation. Once patients are referred, they still have to complete the evaluation process, and then they have to be accepted onto a waitlist. So, what patterns do we see by sex at that stage, particularly the older women?
Yeah, so that's sort of the same sort of pattern as I just described for referral, is that they're less likely to be activated on the wait list, and the disparities are bigger the older you get.
Kidney, older women are less likely to be referred, waitlisted, or receive a living donor transplant. Although deceased donor access has improved, especially after 2009, that's from your paper. Um, I see that in liver, the MELD system historically has disadvantaged women, particularly because of body size and difficulty finding appropriately sized organs can also play a role. I imagine, is that also true for children?
Um, That's a good question. I don't know specifically. I'm not a liver transplanter. Um, children would probably do better with a reduced, like with a split liver than
Mhm.
adults might do. But I'm not sure I can speak specifically to pediatric liver since I'm a nephrologist. Um, yeah.
Okay. No, that's good. I'm just trying to look at your paper and understand some of these things. I think because it's really interesting to know where the gaps are. Maybe there's someone else that is interested in doing more of this research or a hepatologist that's interested in this type of work. So let's talk a little bit about a point that you've made in the paper, which is that clinicians seem to judge women as higher risk for poor outcomes than men with similar profiles. And you mentioned a little bit of that or alluded to that earlier, especially if they are older, have comorbidities or a higher BMI or living with obesity. How strong is that evidence? And do you have any idea what might be driving those judgments or risk perceptions of clinicians?
Yeah, so that's a really good question. I think the things that are driving it are, well, frailty, as mentioned, that women are judged to be frail more than men. And that's, and I'm a pediatrician, so, I put that caveat in there. But there are different ways of assessing frailty, and there are subjective methods and there are objective methods. And using the subjective methods, women are pretty well consistently judged to be more frail than men. Using objective methods, they are not. And using objective methods, I believe that frailty predicts mortality to an equal degree in men and women. So frailty judgment is probably a big part of it. Um, and then the risk associated with obesity seems to be another part of it. Now, why is that happening? That I don't think I can answer really why that's happening. Amanda Vincent and I tried to do a study a few years ago that was studying transplant physicians or nephrologists who refer patients for transplant um, to see if there was sex bias in their judgment of a case. So they were provided just with a vignette.
Okay.
There was no patient in front of them, and that might have been the fatal flaw of the study, but they were presented with a vignette, and in half the vignettes, the patient was female, and the other half, the patient was male. And we were trying to see if, with a similar comorbidity profile, age, BMI, all the rest, whether male patients in these vignettes would be judged differently than female patients, and they were not. They were not judged any differently. However, I think reading a bunch of text is a very different thing than having a patient in front of you that you're looking at and bringing all your social, cultural, conditioned beliefs about is very different than an objective vignette in front of you. So we didn't find a difference. Does that mean there isn't a difference? Not necessarily. Yeah.
Just that it's hard to study.
Yeah. Yeah.
It's
Very
an
hard to
interesting type of
study.
study. Um, so let's talk a little bit about biology and behavior and why some of these outcomes differ. Let's go back to our transplant journey map and move to the next piece. So we've talked about getting to transplant. Now what happens after that transplant? So that's biology, things like medications and survival. And you've heard Dr. Foster talk about medication adherence as being a big issue there, particularly in the pediatric and adolescent population. In your paper, you highlight several biologic differences between males and females that are relevant to transplant outcomes: body size, immune system differences, donor recipient sex combinations. Can you unpack some of the main ones for us?
Sure, I can try. I'm going to leave body size out of it for now.
Okay.
Although not saying it's not important, I'm just going to set it aside. In terms of medication adherence, that is something that is almost impossible to know what the truth is about, sex differences in adherence because there's no perfect way to measure adherence. And I've tried, and a lot of people have tried. So, in adherence research, typically we try to use as many different methods as possible to measure adherence and then get at the truth that way. So in the studies I have done, and I've looked at sex differences in adherence in a couple of different data sets. One data set was from my trial where we used electronic monitoring, and we also used variability in tacrolimus trough levels. And the other data set was from another observational study where we used self-reported adherence and variability in tacrolimus trough levels. You would think that electronically monitored medication adherence would be objective. However, you still have to be adherent to using the monitor. So we consistently showed better. So in children, in young children whose parents are doing it, there's no difference in adherence no matter how you measure it. In older adolescents above the age of about 16, and in the adults that we included in the other observational study, we saw better adherence in females than males. Now, does that mean they really took their medications better, or does it just mean that they used the device better? I can't tell you. We also saw better self-reported adherence in females than males. Does that really mean they took their medications better or that they're better liars? I can't tell you.
Right.
And we know that women are more likely to want to please the person who's um, doing the interview, and so maybe more likely to over-report their adherence. So there's probably a bias towards better adherence by self-report in females than males.
Hmm.
However, interestingly, when we use variability in tacrolimus trough levels, which has been proposed as an objective measure of adherence and is correlated well with graft outcomes, it's never actually been shown to be a measure of adherence because we have no way of measuring adherence. But if you look to see if variability in tacrolimus trough levels is correlated with self-report, it is not. If it's correlated with electronically monitored adherence, it is not. In fact, when you look at sex differences, you see the opposite. So variability in tacrolimus trough levels is higher in females than males. Is that because women actually have poorer adherence? Or is it because there's something wrong with tacrolimus trough levels as a measure in women? And there is some evidence that estrogen interferes with the enzymes that are responsible for metabolizing tacro. And so one of our hypotheses coming out of this is that perhaps variable estrogen levels in young women actually cause higher variability in tacrolimus trough levels and that it has nothing to do with adherence. We don't know that.
Wow. That's
Um, yeah.
something obviously that people need to be looking at closer in terms of doing.
Yeah, that's super hard to study, but it's something pretty interesting that's come out of this. So Could there be differences in adherence? Maybe. Most of the literature would suggest that probably adherence is a little better in women than men, but we'll never know that because there's no perfect way of studying adherence. Other things, other biologic factors that could influence graft survival are differences in immune reactivity. And so there's plenty of literature outside the transplant literature in immunology to suggest that women have a more active immune system than men. And this is actually where studying people across the entire lifespan gets more interesting as well, because so many things change, right? The immune system is immature when a baby is born, and it matures over the course of childhood, probably peaks in adolescence and late adulthood, and then declines thereafter. And so you need to sort of keep that into account while trying to figure out what all these observed sex differences mean. We know that there are more genes responsible for immune function on the X chromosome than any other chromosome, and that X inactivation is actually incomplete. And so women may have a double dose of some of these immune-related genes. So that might be playing a role. Um, and then the interplay between donor sex and recipient sex. Um, there's some pretty old papers that, looked at this as well, that a female recipient receiving a male organ may react against the HY antigen that's expressed on all male tissues, and that there's no analogous female antigen that males would react against. So really the only donor-recipient sex combination that could be problematic would be a male donor to a female recipient. So all of the analysis we have done has included an interaction between donor and recipient sex, so that we're looking at differences in outcomes between male and female recipients of a male donor separately from those who had a female donor.
Interesting. This is a great paper. Everybody should read this paper. All transplant scientists should read this paper. And I think thinking through these questions and understanding at least the data presented in this paper can probably help inform other research questions that we need to answer that are critical to all populations across the lifespan. I mean, I'm biased at this point because I do believe that women need to have better access, and if we're seeing problems, we need to move that forward. So, thank you for doing this work. This is amazing. So, when you kind of look at the big picture, right, access, graft survival, and then excess mortality, do you come away thinking that women get less benefit from transplant than men, or is it more nuanced than that?
Yeah, no, I would definitely not say that. Women get just as much benefit from transplant as men. In fact, in the kidney world, you might even say women get more benefit because women being treated with dialysis consistently do worse than men being treated with dialysis. And
Gotcha.
that's a whole other problem that needs to be solved. But, given that women have higher mortality rates on dialysis than men do, or at least higher excess mortality rates, then, the conclusion is, well, then women should get transplants so that they aren't exposed to that. So, no, women benefit greatly from transplantation. The question is really, how do we make sure that transplant outcomes are optimized for every recipient? And so when we're talking about graft survival, we want to make sure that we're tailoring our treatments so that everybody gets the best benefit and ideally has one transplant for life. And if that means that female transplant recipients get a different immunosuppression protocol than males, that's what it means. If that means that adolescents and young adults get a different immunosuppression protocol than older people, then that's what it means. And we haven't done that yet. We haven't really personalized our treatments. And, people talk about personalized medicine and they want to sequence the entire genome and find the gene. Why don't we just start by looking at how old they are and whether they're male or female? And why don't we do that first? because I think that's going to have more payoff than some very esoteric little detail. I could be wrong about that, but
Seems fundamental, and fundamental things often do have large payouts when you think about them that way. So, if you could speak directly to transplant clinicians, nephrologists, cardiologists, hepatologists, pulmonologists, any of the subspecialty medical specialties or surgical specialties in transplantation, what practical steps would you urge them to take today and tomorrow to reduce sex bias in their own clinical practice?
yeah, that's a hard one because I think we need to actually approach this from a systems level more than an individual level because maybe there's a few bad actors out there, but I think most surgeons, physicians, nurses, everybody who's working the system is trying to do the best for every patient. And
Right.
nobody sees themselves as biased usually. Um, so I think it's a hard thing to do to tell people you are personally responsible for trying to fix this problem. So I think as at a systems level, we need to develop processes where, is every patient referred for a transplant? I think that's unrealistic because I just don't think that there's necessarily capacity in the system to deal with every single person. But, there could be some baseline, easily objective criteria that electronic medical records could flag people as this person should be
Oh.
referred for transplant. And there's a timeline that they get referred at whatever time, and then they just get referred. Whereas those who we know, okay, this person is never going to get transplanted, they'd get filtered out. Um, we need foolproof systems that bypass the human factor, where we're making those kinds of judgments. So we need that in the referral. Um, Waitlist activation, we need more objective means of deciding who gets activated on the waitlist and who doesn't. Again, should we have calculators or, there's always going to be a human factor involved in some way, but the more we can take away from individual value judgments, probably the better it's going to be. Certainly just um, highlighting, to transplant physicians and making them aware that these biases are happening is important. And then at the level of allocation, there are also things we can do. And I think there's been finally some good progress there. So, liver was one area where there was big problems. The MELD score was known
Mhm.
for decades to disadvantage women, and yet nothing was changing. And so since 2023, there's a new MELD, the MELD 3.0, which is deliberately trying to address the sex disparity in allocation that was known to exist for decades. Um, so it is frustrating to see that, it takes 20 years for people to go, oh yeah, I guess we should do something about that. But something is being done. So hopefully that's going to make a difference in lung as well. Disparities were known. There's a newer score that's being used in lung that hopefully is going to help. I think a lot of researchers are now trying to do sex disaggregated analysis and really highlighting those disparities, which is helping shape policy. So those are the things I think that really need to be done. It's very hard on an individual clinician level to do more than just recognize that bias exists and try to fight against it.
Yeah, so it's systematic. Sorry, erase that, Robert. So it's systemic issues. It is not individual bias. And so, can you talk to me now about these research gaps? And if a funding agency gave you a large grant to tackle any of these issues, what's the top study that you would propose right now?
Hmm. I guess I would really love to try to figure out the tacrolimus story, the variability in tacrolimus. It's a hard thing to address in a very foolproof way, but I think it would be really fun to try to figure out if variability in tacrolimus levels, which we know is strongly associated with graft outcomes, was actually being caused to some degree by variability in estrogen levels in young women. I think that would be a very useful thing to know. How you would address that then is an open question, but you could try to address it at the same time, I guess. I think that that could be a useful thing to study.
Very cool. Very cool. I'd support that research if I could. I have another question for you because sometimes we get patients and families that listen to our podcast, and especially women who are considering a transplant. What message would you want them to hear from the work that you've published?
Um, so I guess, the main thing would be women benefit from transplant. Anybody with organ failure benefits from transplant. I mean, if we're talking about lung, liver, or heart, it's a matter of life or death. Uh,
Yeah.
Women deserve transplants as much as anybody else. Um, Women benefit from kidney transplants just as much as anybody else and are as just as deserving. So I think, advocate for yourself, ask to be referred. Um, Talk to your friends and loved ones about living donation. Uh, Women have great outcomes with transplant. When we talk about sex differences in outcomes, we're not talking about huge differences that, women do so much worse. They're small differences. And so everybody benefits enormously from transplant.
These differences that you've identified scientifically and from an epidemiological perspective help us to fix problems and understand where we might be able to intervene. Not that women don't benefit from transplant, they absolutely do. And so, thank you for making that point because I do understand that patients and families might see something like this and be like, "Oh, am I not going to get as much of a benefit given survival or more, other types of challenges there?" So, thank you for making that point. And my final question to you today is if our listeners remember just one key point from your review from the science, what should that be?
Hmm.
You've made a
One,
lot of good ones.
uh, I guess, my biggest takeaway, can I give you two?
Please, I would love to.
Okay, I'll give you two. One is that we can't underestimate the impact of bias in access to transplant on everything that happens downstream. Um, and I'll just give you a quick example. So if women have to be healthier to get referred, to get onto the wait list, to get a transplant, then if we see better outcomes in women than men after transplant, we should not be surprised, right? Because we are selecting the very healthiest people who are going to survive the longest. And so we should not conclude, oh, women are fine, everything's great, everything's great. No, let's solve the access problem, and then we'll look again and see, is everything fine? Maybe it is. So that's one point. Access is key, and it has a huge impact on all the outcomes. And the other point is there is huge value in studying the entire lifespan. Um, we learn something by looking at little children and elderly people and everybody in between. Something that we see in adults, we can help us understand what we see in children and vice versa. And so I think there's huge value in studying the whole lifespan.
I love it. Dr. Foster, thank you so much for walking us through this complex and critical topic. Your work makes it very clear that while biological sex differences exist, disparities that we see in access and outcomes are also potentially driven by policy choices, clinical practices, and social norms. Those are all things that can ultimately be changed. For those interested, the paper is titled Sex Disparities in Transplantation, Access and Outcomes, an Overview. It's been published in the Transplantation Journal in the April edition. It's available online now. You've been listening to the Transplantation Podcast. I'm Dr. Macy Levan, the social media editor for the Transplantation Journal. If you've enjoyed this episode, please subscribe and share it with your colleagues. Thanks for listening. We'll see you next time.
Thank you very much. I really enjoyed it.